I'll spend the next few minutes talking about migraine headaches and present to you the results from our publication on migraines in patients with SCAD from the iSCAD Registry. So first, just in terms of definition, what is a migraine? This is the International Headache Society classification. You have to have had at least 5 episodes lasting 4 to 72 hours. Classically, these headaches are unilateral. They may be pulsating, moderate to severe pain, aggravated by simple activities such as walking or climbing stairs. So this discomfort causes avoidance of those activities. You classically have nausea, vomiting, photophobia, and phonophobia, which is a disturbance related to sound or light or sound, respectively. And you may have an aura, you may not, but if you have an aura before the headache, that's a neurologic disturbance that may be visual, sensory, speech-related before the headache. That's usually sort of a premonition. And in terms of what we know about migraines and what we don't know, there are increased risk for cardiovascular events. It is the most common symptom in SCAD, and it is increased in patients with other vascular abnormalities too. And this schematic here illustrates that there is this overlap in between migraines and the association with vascular conditions, but the association relationship is not well understood. It's at least in part due to genetic factors, hormonal factors, and or environmental factors. So a lot to learn here in a area of research interest. We published this in the past about FMD patients and headaches, and we found that approximately 2/3 of FMD patients have headaches, and many of those have frequent headaches defined by daily or weekly. They were often younger in age at the time of FMD diagnosis. They were associated with dizziness and pulsatile tinnitus symptoms. And if you've had a carotid dissection or aneurysm, there's an increased risk for headaches as well. And not surprisingly, a history of depression was associated with headaches in FMD patients. This is a previous study on SCAD and migraine headaches that showed the lifetime prevalence of migraines in SCAD patients was approximately 40%. Over half had FMD, and 2/3 had extracoronary vascular abnormalities. There was an association with depression as well, and an increased risk for chest pain within that first month after the SCAD event compared to those without migraine headaches. Fortunately, we have not seen a significant difference in SCAD recurrence between patients with or without migraines. So here are the data from the iSCAD Registry that was published a few years ago. At the time, we had 773 patients with available data, and 46% reported previous or current migraines. Migraines were more common in women. They were more likely to have fibromuscular dysplasia. Converse to the FMD patient population I presented to you a few slides ago, there was not a significant association with carotid artery dissection and migraines, but there was an association with depression and anxiety. And these figures here are from the publication. In terms of frequency of migraines, 18% had frequent migraines defined by daily or weekly, 23% had at least monthly migraines, and approximately 58% had less frequent migraines. In terms of treatment, 32% of patients who have had a SCAD event were still on triptans at that time, which are contraindicated in SCAD, as most of you know, because it's a vasoconstrictor and could be potentially harmful for our fragile blood vessels. And 53% were not receiving treatment or were unsure if they were receiving treatment. 17% of patients were on prophylactic medications on a regular basis to reduce the frequency and severity of these headaches. So a lot of opportunity here in terms of education, as our patients should not be taking triptan antibiotics, triptan migraine treatments, for example, and 53% not receiving treatment that may improve their symptoms and quality of life. So a lot of opportunity there. And this was the first trial that looked at disability associated with migraine headaches in patients with SCAD. We found that most patients had little to no disability. Approximately 25%, however, had moderate to severe disability, and this was defined by the MIDAS score or the Migraine Disability Assessment. So in conclusion from our study, we found that migraines were common, frequent, and a source of disability in patients with SCAD, and the association with female sex anxiety and depression may provide some insight for potential treatment modalities. And as a summary in terms of treatment, here are some other important points: that there are no established guidelines for treatment in patients with SCAD. We should address other risk factors such as smoking. Again, avoiding vasoconstrictors, very important. Migraines tend to improve after a SCAD event, likely due to the initiation of beta blocker therapy, which is a prophylactic medication, so that's helpful. And a newer agent called CRP inhibitors appear to be safe and effective. So as a summary here, migraines are the most common symptom in patients with SCAD. It's very disabling, associated with depression and anxiety. It's unclear the precise mechanism, likely associated with vascular injury, genetic predisposition, and hormonal factors. And treatment generally is the same as migraine headaches without SCAD, in patients without SCAD, except with the exception of avoiding triptans, and individualized approach is recommended. And thanks so much for your time, and looking forward to the rest of the conference.